will keep coming in.
Yes.
So, good evening, everyone. Um, I'll begin to welcome the guest speaker we have today, Dr. Ikenna Ikekeonwu, a consultant pulmonologist with extensive experience in the diagnosis and management of adult respiratory diseases. So he manages both acute and chronic respiratory diseases. He's currently practicing at Federal Medical Center, Asaba, where he plays a key role in the delivery of specialized respiratory care. He's also committed to medical education and training. And as we can see, he's here to educate us and played an important instrumental role in the Department of Internal Medicine at FMC Asaba, attaining pulmonology accreditation from the West African College of Physicians in 2023, a key milestone in advancing specialist training in the region. His clinical interests include interventional pulmonology and advancing lung health through improved diagnostic and therapeutic techniques. He's also deeply devoted to promoting the development of African people, both in healthcare and beyond. So outside of medicine, he has active interest in agriculture, nature, and sports. Please, can we begin to send in our lovely emojis to welcome Dr. Ikekeonwu in our midst? So we are happy to have you here. And
Glad to be
it's
here.
a
Thank you very
privilege.
much.
So now you have the floor.
All right. Thank you very much for the kind words and the beautiful introduction you have made of me. All right. I'm grateful. Okay. So yeah, I want to greet everybody here, and thank you all for coming for this presentation. And we are gathered here. I'm here with you people. You guys are a noble group of people who are here to discuss with me about some basics of respiratory failure. Okay, so let's make good the time. Yeah, the way we're going to share the time is that we'll try and breeze through the essential points, and then we'll make room for questions which can come from the things that have been shown and any other thing related to respiratory failure. Okay, so here is what we have. I hope we can see my slides. Can we, if the slide transitioning, can we see it changing? There's a bit of a lag. Hello?
Yes, it's beautiful. It's
Okay.
changing. We
Okay.
can see that.
Okay, thank you. All right, so this is the outline we're going to use. After a very sharp introduction, we'll talk about the learning objectives, sample a couple of sample questions, and then the interesting the bits, and then we'll conclude. Okay, before we go to questions. Okay, so basically, the reason we are interested in respiratory failure is that it comes up a lot in medical practice, you understand, whether acutely, the one that is, rush, or chronically, the people who are stable, but they are unwell. So respiratory failure is actually quite common. Another thing about respiratory failure is that when people die, a lot of the time, what the point through which they transition is cardiorespiratory arrest. So respiratory failure comes up again, even towards the end of life, and it cuts across many diseases. So for this reason, we are interested in knowing what is this respiratory failure, how can we recognize it, and what can be done, what are those situations in which something can be done. All right, so let's move on. So by the end of this brief talk, we're going to know about respiratory failure, how it comes about, the things necessary, the components needed to make respiration happen, how respiratory failure comes about, the acute respiratory failure versus chronic respiratory failure, and how to recognize respiratory failure and how to manage it. All right, this is an overview, so we'll try to be brief and as we go. Okay. All right, so let's go for some sample questions. So you might see some things which, of course, I'm sure you guys know these things, but it's just to get our minds, running and wrapping it around what we're talking about. So the first question says, which of the following is not a type of respiratory failure? Option A, hypoxemic respiratory failure. Option B, type 2 respiratory failure. Option C, type 3 respiratory failure. Option D, type 4 respiratory failure. And then option E, rise and stew respiratory failure. We can see the picture there shows some rice, you understand. So even though the answer is not, I don't know if my mouse pointer is showing anything. Okay, but the answer that is wrong clearly is there's nothing like rice and stew respiratory failure. So this is an obvious one. that means that the other answers are obviously correct. So the next one talks about which of the following is not a functional component of the respiratory system. Which of the following is not a unit of function of the respiratory system. So option A, pump; B, pump controller; C, healthy skin and toenails; D, gas exchange units; E, circulation, pulmonary and systemic. So the obvious option that is wrong here is the healthy skin and toenails. It has nothing to do with respiration. These questions might look silly, but it's just they are supposed to get our minds working and then also direct our thinking towards what will possibly be the correct answer. All right. So question 3 asks, this is the last one, don't worry, I promise, but we're getting into the main thing. So the last question on this pre-quiz says, which of the following is a common symptom of respiratory failure? Option A, difficulty with breathing; option B, fever; option C, muscle ache; option D, itchy eyes; option E, neck stiffness. The obvious answer here is difficulty with breathing. I mean, it's respiratory failure. Okay, so having gone through that part, which I hope didn't bore us too much, let us go to, the next aspect, which gives us, we're going to talk about the relevant structures that make respiration happen, the relevant anatomy and the physiological units that make respiration happen. So the respiratory system basically is is any collection of is the collection of those organ systems and tissues which function together to enable an individual to achieve gas exchange. You understand? So those parts of the human body, which when they are working together, the end result of what they are doing is that the person is exchanging gas between the environment and the person's internal milieu. So, and when we say gas exchange, it means exchanging oxygen and carbon dioxide between the blood and the atmospheric air. So that is, it's important for us to know what we're talking about when we say gas exchange. You understand? Exactly. All right. So, what are these functional units? What are the things that come together? So we have grouped them into like 5 things. So we call them names like the pump is, the respiratory muscles. So those muscles, they are typically associated with the chest. You understand? The diaphragm sits, in fact, it forms the floor of the chest, of the thorax, and then the intercostal muscles, they wrap around the ribs. So these are the main muscles involved in moving. They move the rib cage, they move the thoracic cage, so that it acts like a pump. You understand? So they comprise the pump component of the organs of respiration. So they are classified under pump. Then pump controller, of course, now those muscles cannot work on their own. They have to receive signals from the brain, from the nervous system. Those ones comprise, pump controller. Then the airways is the conduit through which the air has to pass. Now that's, the nose, mouth, nasopharynx, glottis, larynx, trachea, and then the other parts of the airway, the lower airway. That conduit through which the air has to pass to get to the gas exchange unit. You see, so these are the things that all these things, and then of course the circulation. The circulation is where the blood comes in contact with the gas exchange units, that's the alveolus, and then as it's coming in contact now, it is releasing carbon dioxide into the alveolus, and then it is getting oxygen from the alveolus. That's the gas exchange. So these things, they have to be working in sync. You understand? The brain gives a signal to the muscles contract, and then they, make the thoracic cavity hollow. The air is sucked into the conduit, which is the airways, and it gets into the gas exchange unit. And the gas exchange unit, the air interacts with the blood, and then the one that is going in, that is oxygen, the one that's coming out is carbon dioxide, and then the blood now circulates it to the body. So all these things, they have to work together, and if they are not working together, respiratory failure will result. You understand? So this is just some diagrams that support what we have said. I hope my mouse pointer is catching some of them. This is just to talk about the mouse, the pump controller. I'm resting my mouse on the diaphragm, and then the intercostalis muscles. These other ones too, where my mouse is now, is the accessory muscles. They are not used in quiet respiration, but they come into play when the person is, when somebody is forcefully respiring, like doing vigorous exercise or during acute respiratory failure of some types. Okay. So now we mentioned, the purpose of the respiratory system is to achieve gas exchange. Um, the gas exchange is what we're trying to show here now. Look, this is the alveolus. This one that looks like a ball, that looks like a sack with an open end, is the alveolus. And then the carbon dioxide is coming out of the blood. This blood is the blood that is perfusing the lung units. The carbon dioxide comes out and then comes to the alveolus and goes out, and then oxygen comes in and then goes into the blood. Okay, so let's make good the time. So now, if all these things are working together, the air is coming in, getting exchanged and everything, then we will see that the levels of these gases in the blood, like carbon dioxide, see my mouse pointer is pointing at carbon dioxide and oxygen, we will see that the levels have a range within which they are considered to be healthy. So if somebody is respiring well, so this person's carbon dioxide, for instance, this thing here, it will range between 35 and 45 millimeters of mercury, otherwise known as 4.5 to 6 or 4.7 to 6 kilopascals. So these are the kind of values we will get if we measure somebody's arterial blood and the person is healthy and well and everything is fine. And then for oxygen, its own values are it varies depending on the textbook you're reading, 10.5 to 13.5, 11 to 13. That you will see them hovering around the same thing. So 75 to 100 or 82.5 to 97.5. So these are the kind of values you're going to see, and you know, okay, this person is respiring well, and there is no issue. The other ones I mentioned are not critically so important, like base excess, although they do come up in the context of chronic respiratory failure. Now, this first set of values I gave you are values obtained on an arterial blood gas of a normally respiring person. Then the second one is a pulse oximetry, which is an approximation of the oxygen component of the arterial blood gas. It is not always very precise, but it's a non-invasive approximation. Okay, all right. So respiratory failure, we've said what it means for respiration. So and we've mentioned that the major function of the respiratory system is gas exchange. There are other functions of the respiratory system, but the one that's important to us now is the main function of respiratory system, which is gas exchange. The respiratory system has like 5 or 6 other functions, but please, we're focusing on the one of gas exchange, which is actually the most important. So now, a condition where respiratory system fails in one or both of its gas exchange functions, from that diagram we showed the gas exchange is now what we're taking oxygen into the bloodstream and we're sending carbon dioxide back out. So it is when one or both of these has failed that we're referring to it as respiratory failure. So typically, when this happens, the values of the gases in the blood of the person will start changing, and it will change to a particular degree at which we will now say, this person has respiratory failure. And that is the degree I'm pointing at in the second part of this slide. So you can see it now, typically, for somebody who is in respiratory failure, the respiratory failure is only said to be a respiratory failure when the person's oxygen level goes below 8 kilopascals. If it's between normal value but not as low as below 8 kilopascals, that person is in hypoxemia, not in respiratory failure. Now, the person's if the case is that the person's in my mouth, if the case is that the person's carbon dioxide is not elevated at the same time, and the person has only a low blood oxygen, less than 8 kilopascals or 60 millimeters of mercury, then that person is said to have type 1. So it's hypoxemic. That's the type 1 is the the one that has to do with only oxygen deficit. You understand? In people who have type 1, the oxygen is reduced, but carbon dioxide is normal. It's definitely not elevated. In some states of type 1, the person's carbon dioxide is even reduced. You understand? But it is never elevated. So type 1 is oxygen is hypoxemia. That's why it's called hypoxemic. And then for it is hypoxemic respiratory failure, otherwise known as type 1. Type 2 is hypercapnic. It is when you have carbon dioxide being elevated greater than the upper limit of the normal value that you had in the slide before this one. So the carbon dioxide is elevated, and in addition, the oxygen is also reduced to less than 8 kilopascals. So we can see from what I have just said that in all types of respiratory failure, oxygen is always less than 8 kilopascals. So the issue now that distinguishes type 1 from type 2 is whether at the same time is the person having carbon dioxide that is elevated more than 6 kilopascals. Sorry, I know some of us might be used to 45 millimeters of mercury. I actually prefer millimeters of mercury, you understand? So, but just for ease of talking, I'm using kilopascals now. So in type 1, oxygen deficit is alone. Type 2 is oxygen deficit plus carbon dioxide excess. So type 3 now and type 4, these things are more of pathophysiological definitions. So type 3 respiratory failure is when you have respiratory failure that is occurring in the context of somebody whose lung is relatively, intact, but those sacs of air, they have closed on themselves. You understand? They have closed. So as a result of that, you're not having much oxygen, going into them and carbon dioxide coming out. Now, the issue here is that carbon dioxide is actually a more soluble gas than oxygen. So when you have a collapse of a part or a lobe of the, or a significant portion of a lobe or a lobe of the lung, it affects oxygen more because oxygen is, how will I describe it now? You are more likely to have efflux of carbon dioxide than influx of oxygen. That's the reason why most of these ones, when something starts happening, oxygen is always affected first. That's the thing. So type 4 is the one that's related to shock. Remember we said in type 3, the lung is collapsing upon itself. That's not the issue in type 4. In type 4, everything is intact, but the blood is not perfusing the lung well. So the person is really having a low volume state, and you don't have blood coming to pick up the oxygen from the lung or send its carbon dioxide away very well. Okay. Now these are the 4 classifications. The main ways of classifying respiratory failure are based on the gas derangement type, and then based on whether it is acute or chronic. That's why the last line here, we're talking about acute or chronic. Acute respiratory failure, ARF, it develops within minutes to hours. You understand? To maybe a day or two. But then the one of chronic is the one that has been there. The person has been suffering with it for weeks to years. You understand? Weeks to months to years. So that's the distinction based on the time it has taken for the thing to develop. If it develops very, very quickly, it is acute. If it develops slowly, usually over weeks to months to years, that is the chronic type. One of them is more life threatening. The other one, while life threatening, but not as much as the acute one. Okay. Sorry for spending a lot of time on that, but let me see my time. That's how time goes. All right, guys. So these next 2 slides, don't worry, we can always look at them. It's just for us to see that there are two groups of causes of respiratory failure. We can bunch them into, group them into type 1 and type 2. We know what type 1 means, we know what type 2 means, you understand? So we can see type 1 causes on the left, we can see type 2 causes on the right. Type 2 causes are many, you understand? So I had to create a second slide for them, and that's what we're seeing here. Okay, fine. Let's move on to the next one. So for type 1 or hypoxemic respiratory failure, it's usually will result from some underlying mechanisms. So those underlying mechanisms mean that what is going on at the level of the lung or at the level of the respiratory system that is making the person to manifest with only oxygen lack. So now, they have been grouped into about 5 or 6 groups. Ventilation perfusion mismatch simply means that in such a situation, more air is coming into the respiratory system into the gas exchange units than blood is coming to meet it. You understand? So there's a mismatch. You understand? That's what we call V over Q. But let's not go. Let's not bore you guys with that. So we have another one called right to left shunt. What right means that the right side of the human circulation normally contains deoxygenated blood, and the left side contains oxygenated blood. That's the one coming back from the lung towards the general circulation. So when you now have any connection whatsoever that is causing blood to spill over from the right-sided circulation, that's the right heart, IVC, SVC, if you are having any kind of connectivity or a septal defect to cause blood that is poorly oxygenated, instead of going to the lung to get oxygen, is now spilling over into the blood, returning to the systemic circulation. That person will have low oxygen values. Hypoventilation simply means ineffective breathing, ineffective air coming in and out of the respiratory tract. So while that can cause type 2, it will definitely also cause type 1. Now, the efficient limitation is a situation where the air is coming in, but due to the fact that something is going on at the level of the respiratory membrane, that alveolar sac now, with those layers we showed you, have suddenly for some reason become thick, whether it is fluid or whether it is cells, whether it is fibrous tissue. But the thing is, that interface between the alveolus and the blood capillaries around it is now so thick that oxygen cannot diffuse in well. That will cause a type of type 1. Then reduced fraction of inspired oxygen. Obviously, if somebody is in, let's say, in a place like a high mountain, or in an aeroplane, or in a burning building, or in a house where they are doing experiment, and suddenly oxygen got consumed, the amount of oxygen available to the person will drop. So such a person can develop hypoxemic, respiratory failure. Then, if the person has increased oxygen extraction, we mentioned type 4, which is sluggish flow of blood. So the way that one happens is that when blood is circulating from the periphery, in somebody who is having a weak heart, the heart is not pumping well, so blood is moving sluggishly, and then as it's moving, sorry guys, as it's moving slowly through the body, it's giving off so much of its oxygen that by the time it comes back to the lungs, the lung is not even enough to give it enough oxygen that it needs. So it still goes back again to the rest of the body. It's still low oxygen. That is increased oxygen extraction. That is the issue because of the sluggish flow of blood. Okay, these 5 groups I said now are descriptors, are underlying pathologic mechanisms for causing type 1. You understand? Oxygenation failure. Then hypercapnia comes from, where you have severe global hypoventilation. That is, the air that is coming in is not really getting too well to the lung exchange unit before it goes back out again. Or it can result from ineffective alveolar level hypoventilation. So what I mean is this: it's the first one I described is the air coming in from the breathing is not okay, or the person can be coming in, but for some reason, due to things like severe bronchoconstriction, you understand, narrowing of the lower airways, the air is trying to come in, but it's not fully getting to the alveolar level at the alveolar level hypoventilation. And both of them will result in hypercapnia because carbon dioxide typically needs air to be flowing in and out of the lung well for carbon dioxide to be washed out. And carbon dioxide actually, behaves well when it meets fresh incoming air. It diffuses rapidly into it. But when the air is now stayed, it's not moving well, the carbon dioxide builds up in the air and cannot, due to the lack of a diffusion gradient, cannot escape from the blood into it. Sorry. Whoops, I have a small amount of time, but let's move on. So, the consequences, of course, for somebody whose oxygen level is not good, is a problem. So it's the things like mental status changes will develop. You understand, and these things are as a result of the fact that oxygen is needed to drive metabolism. If you don't have metabolism, metabolism is needed to generate energy in the human body, and all the cells. Energy is the currency, and oxygen and the ATP are the energy currency. Especially ATP is the energy currency of the cell. So if you don't have ATP due to not having oxygen for the electron transport chain, you will not basically be functioning well. Sorry, guys. I hope people are still hearing me. Sorry, are we still together?
Yes, we are hearing you, sir.
Okay,
We
thank
can
you
hear
very
you.
much. Thank you so much. So, oxygen is needed to, drive metabolism, and then, and if that's not the case, cells will malfunction, including the brain, and the mental status changes will happen. So, this is what happens. This can happen in untreated acute hypoxemia. Now, for acute hypercapnia, a similar thing can happen because if there's CO2 that is building up, CO2 it has a way of causing things like headache because CO2 is a vasodilator. It dilates the vessels of the brain, causing things like headache, flushing, and then causing ultimately drowsiness. You understand? CO2 narcosis, and that drowsiness can lead to coma and stupor and coma. So these things I described are things that occur in the relatively acute, short-term, hours to days setup. In the chronic, the person has time. The person has time. The person will not die immediately, right away, but the person will have time to have some compensatory bodily changes like polycythemia developing. Um, the human body actually responds to hypoxemia by a number of changes. One of them is stimulating the fibroblast-like cells around the kidneys to release a molecule that makes the bone marrow to produce red cells. So the body is trying to produce red cells so that those red cells can carry any small available oxygen it sees, it will carry them. You understand? So polycythemia is another one. Pulmonary hypertension is definitely there because hypoxemia makes the pulmonary vessels to constrict, and whenever they constrict, the pressure in them builds up. So that's pulmonary hypertension due to long-standing hypoxemia. The renal competition is what I just described. Those peritubular fibroblasts, they release erythropoietin. That is it's happening at the level of the kidneys. That's why peritubular tubular is in the kidneys. Okay, let's move on. Clinical features. How do we know somebody's having respiratory failure? One giveaway symptom usually is dyspnea. You understand? It is very, very unlikely you hear of somebody having respiratory failure and the person didn't at some point or all the time talk about how the person was, having this dyspnea is a sensation of insufficiency of breathing. You understand? Where the person is feeling that his breathing is not enough to give him breath. It sounds silly, you understand, but that's the concept of dyspnea. You understand? It's a subjective feeling of insufficiency of the breathing process. So that is it's an almost unifying symptom in people who have, whether it is acute or chronic. Or you understand, the presentation of acute will be, of course, will be more dramatic, shorter time, rapid onset, rapidly progressing. The one of chronic is going to be a longer time. We said weeks, but then you see that the person at the same time is saying he's not breathing well. You understand? The person, some of them will call it getting tired easily. All right. Other symptoms are related to respiratory system, like things like cough. Now, coughing comes from, trying to a forceful expulsion of air, and presumably in response to an irritant or whatever stimulus, either occurring at the level of the lung or outside of it. So wheezing is, the noisy breathing that is heard when somebody is trying to breathe out air through a narrowed airway. So it can happen in breathing out. It happens more commonly in breathing out than during breathing in, although it can happen in both. Okay, sputum production. Of course, sputum is the expectorated respiratory secretions. That is sputum. So when the person is producing a lot of sputum, these are things that can be seen. They are not the things that on which we center the diagnosis, but it's things that we can come across in somebody who's having respiratory failure. Sorry, okay, it's almost I planned that by 7:30 we'll go over to questions on this, but don't worry, I'm almost there. Other things are coughing up of blood, use of accessory respiratory muscles. Like we have already mentioned mental status changes. We know why. We mentioned things like confusion and drowsiness. And cyanosis is when somebody has a bluish tinge to the blood owing to a high circulating amount of deoxygenated hemoglobin. All right, so how do we diagnose and investigate? How do you investigate and diagnose respiratory failure? Of course, the central test we are trying to use to diagnose it is the test which will give us those results we showed you in the earlier slides. This test is called the arterial blood gas. What it involves is using a special needle, a special syringe to get an arterial puncture so that the blood goes from the artery straight into the needle without atmospheric air contaminating it at all. And it goes straight into the needle. Of course, because hemostasis is secured and everything, and then the artery and the arterial blood is taken to an arterial blood gas machine, looking like the one we are seeing in the picture. We can see towards the bottom of the screen the syringe containing the arterial blood. Arterial blood is normally bright red when it comes out like this one. This one is brightly reddish in a way, and then it shows values. It shows values. If we can see the values here, we can see the person clearly has hypoxemia, and it's most likely is a type 1. Anyway, so other things that we can check, we mentioned pulse oximetry. Pulse oximetry, they are supportive. The main investigation for diagnosing a respiratory failure, whether acute or chronic, is the arterial blood gas. Venous blood gas can be used, but it one has to have special, not really special, but it takes somebody who has the knowledge and can know how to synchronize the value of venous and arterial. So other tests are imaging like chest X-ray, pulmonary function tests, overnight oximetry, hemoglobin. Things like overnight oximetry, hemoglobin, and pulmonary function tests, they don't serve too well in the acute setting, but then they serve well for when you're assessing somebody who has chronic respiratory failure. Okay, all right. So treatment of respiratory failure, and we have recognized what respiratory failure is now. You understand? We recognize that things can cause it. All right, like the things we listed on those two slides that have type 1 and type 2 causes. Now, how do we treat it? So the treatment, what we're going to do for the person depends on how is the person presenting. You understand? What type have we seen, and then what is the severity of what the person is coming with. So the type, of course, now we're talking about type 1, type 2, type 3, type 4. You understand? If it's type 1, is hypoxemia, and you address the hypoxemia by giving oxygen supplementation, by giving oxygen support. You understand? And if it's type 2, it is hypoxemia plus hypercapnia. So it means that it's not only oxygen you're going to be giving the person, you're going to be giving the person oxygen, and you're also going to be adopting measures to remove carbon dioxide. You understand? That's if it's type 2. That's what I'm talking about, oxygen plus or minus ventilatory support. And if it is type 3, we know what type 3 is, collapse of the lung. That means that for such a person, you will have to adopt mechanisms that will help in opening that lung. You understand? Opening that portion of the lung, yes. Then if it is type 4, circulatory support is needed. Now, that means that the person's blood is flowing sluggishly. Okay, why is it flowing sluggishly? Did the person have, heart failure? Did the person have myocardial dysfunction, myocarditis? You understand? So what it is, you treat it. So that's why point 3 here says always address underlying cause where feasible. You understand? And then the duration, of course, the way we treat acute respiratory failure is not going to be the way we treat chronic respiratory failure. You understand? Because there are two different mechanisms on the line. There are two different things ongoing. There are some subtle differences which we can go into in the questions and answer portion. So some of the instruments we'll find ourselves using are things like nasal cannula, whether it is low flow nasal cannula or high flow nasal cannula for people with type 1. Also, venturi mask as well can be used for people with type 1, because the idea is we're trying to give them oxygen, but we're also trying to achieve some flow of air towards them. Then, if somebody is acute and the person needs ventilation, but it's not going to be the intubation time, the person will make do with something called bi-level PAP or NIV. And we can never forget, if the person is too unwell to maintain his or her own breathing normally, the person gets to be put on a tube. The person has to have the tube put inside the person's trachea. Sorry. Okay, please give me 2 more minutes. Okay. Chronic respiratory failure, of course, we have things like LTOD, home NIV, pulmonary rehabilitation, and pharmacological and psychosocial management. So these are just some pictures to show some of the instruments that we use. All right. So now, for respiratory failure, there's a strong role for physiotherapy, both in the acute and the chronic in certain instances. And what are these interventions which physiotherapy would offer for somebody who is having acute or chronic respiratory failure? Things like airway clearance, you understand? So now if somebody has a collapsed lung or the person has a lot of secretions, So the idea is that we're trying to take secretions away from the lung so that it stop blocking the lung and the lung is collapsing. And also, so that when we're trying to give the person air, or whether it is even if it is things like CPAP or bilevel PAP, the air will not force the mucus down the wrong way. Do you understand? So the people will need airway clearance, and the airway clearance, techniques. You understand? So people will need breathing exercises. Breathing exercises have a lot of importance. So if somebody who can do, thoracic exercises in experience, in breathing in, and then breath holding exercises. So things like mobilization and positioning. Sometimes when you come and you see somebody and the person is lying abnormally, like with the person's head arched forward, you reposition the person into what we call the sniffing position. So basically, in the acute phase, some physiotherapy interventions are very, very, very helpful actually. So in the chronic respiratory failure, in the interventions which we have in the acute phase that are still carried over include things like airway clearance. You understand? Then others will now be things like pulmonary rehab, energy conservation, psychosocial support, exercise training. You understand? The person is trained to manage the person's fitness as he is. So this is the summary of what we have so far. You understand? So we can now, due to the time being against us, let us quickly go through this last 3 points. Which of the following is incorrect? Having heard all that we have heard, my friends, which of the following is incorrect? A, we're looking for the one that's not correct, so please let's be mindful. A, arterial blood gas is the central test for diagnosing respiratory failure. B, physiotherapy can help in managing respiratory failure. C, oxygen therapy is indicated instead of ventilation strategies for type 1 respiratory failure. D, the lung is the only functional unit of the respiratory system. E, a blood gas showing a raised PCO2 is in keeping with type 2 respiratory failure. All right, I'm sure all of us got the answer that is wrong. Yes, and the one that is the wrong one, of course, is D, where it says the lung is the only functional unit of the respiratory system. No, it's the gas exchange point, we understand, but then there are other functional units which help in coordinating the respiratory process. So in summary now, we've looked at respiratory failure as something that results from the failure of gas exchange. We've understood that respiratory failure is diagnosed primarily using a test called an arterial blood gas, and then other tests, of course, now support it, and at the same time try to expose what is causing it, all this in the X-ray and everything. Then we understand that respiratory failure is treated by means of oxygenation with or without ventilatory support, and this is helped in certain situations, in indicated situations by physiotherapy. All right, so these are the references I used in gathering the material, and I thank everybody, please. And I'm sorry that we've overshot the time, but I'm happy to hear the questions now. So sorry. All right, thank you very much, everybody.
Wow, wow, wow. Thank you, Dr. Ikekeonwu. I
Mm,
mean, this was really beautiful. Can we send in our emojis? I mean, the
mm,
beautiful thing is that you really simplified it. So the students here are
mm,
also carried along, I'm sure.
mm.
You use the simple terms for us to understand it better. Thank you so much, sir,
Thank you. It's a
for
pleasure.
this wonderful
No,
presentation.
it's
We
an
are
honor.
grateful, sir.
It's an honor.
Please,
Thank you.
can we send in our questions? We can type in, or you can raise your hand and indicate, and then you unmute yourself to ask your questions. Okay, we have a hand up. We have Oluwaseun Ayebo.
Mm.
Thank you
Can
for
you
the presentation.
It's a pleasure,
Can you
please.
hear me?
Yeah, I can hear you very well.
Yeah.
Yeah,
Thank you for the presentation. I really appreciate that.
you're welcome.
Very comprehensive
You're
and
welcome.
very detailed at the same time.
It's a pleasure.
But the question I have is
Yeah.
for patients back at home
Mm-hmm.
who need support with long-term oxygen therapy,
Mm.
are they able to afford it?
Okay. Yeah. Okay, good. Okay. Yes. So yes. Do I answer the questions right away, or do I compile them? What do we do? How are we doing it?
I
Hello.
think let's ask the question as it comes. I think
Okay,
that
very
makes
good.
it easy.
Yeah, that's beautiful. Yes. For health, the thing is, it will be a lot better if there was, funding, health insurance funding that would cover it, because it actually is a huge undertaking. It's actually a huge financial undertaking to be able to prescribe, to be able to procure the things needed for health thoughts. That's the truth, because health thought simply means having a flow of oxygen given to the person for at least 15 to 16 hours. That means that the person can even need it for 24 hours. Once 15, it means minimum. You understand? And you can imagine what that means. It means that that person needs to be on oxygen. And where is the oxygen going to come from? It can either come from cylinders which are filled, or it can come from a concentrator if the person is lucky and the person needs a relatively low flow. You understand? So these people, it's really challenging. That's the truth. The truth is that it's almost not affordable to the common Nigerian person. That we have to be honest. A lot of my patients, they struggle to be able to afford it, to start it, and then to be able to maintain it. So yeah, the answer is that it is hard to afford. I'm sorry, but it's not a great answer. But yeah, that's the truth. I'm sorry.
All right. Thank you so much. Thank you.
Yeah, it's a pleasure. Yeah, we want more questions, please.
Okay, we have Dennis. Dennis, you have the floor now.
Hi, Dennis.
Hi, can you hear me?
Oh, of course I can. Please go ahead.
Thank you very much for the nice presentation.
It's a pleasure. It's an honor.
It's hard for me to pronounce, but
Yeah,
I'm sorry.
Ikekeonwu. It's a West African name. Don't worry. Go ahead.
Okay, my name is Dennis, a cardiopulmonary physiotherapist.
Lovely.
From Tanzania.
It's a pleasure.
Yeah, I just have I wanted a few clarification from you. It's not actually the questions, but on the part of investigations.
Yes, please.
Yeah, I know the ABG is like a gold standard for respiratory heart failure.
Yeah, definitely.
But it's a kind of invasive investigation.
Yep.
Do we have any other non-invasive? Yes, I wanted to know if there is any gold standard like non-invasive apart from ABG.
Okay, sorry.
The other question. Oh, you want to respond?
No. Don't worry. Yeah. If I respond now, if I respond tomorrow, it's going to be the same answer. Go ahead, please.
Okay, thank you very much. The other clarification I wanted from you, doctor, is just, as physiotherapists, one of the management is a mobilization.
Yeah.
When you say mobilization, we take this patient maybe from lying to sitting, standing, and walking. But if this patient is in non-invasive ventilator, the CPAP, the BiPAP, or invasive ventilator, what is your advice? Because some doctors, they hesitate that you cannot take my patient out of bed because he's in vent. So what is your advice on that? Thank you very much. That's a few questions for me.
Thank you so much. Very great questions. Thank you so much for the questions. That is good. The first one, let's have a look. Yeah. So, any non-invasive alternative to ABG? Yeah, we've got things like capnometry. But the problem, capnometry is when we measure the amount of carbon dioxide in the person's exhaled air. That exhaled air typically is measured at the level of the nose or mouth. So what it tells us, it gives us an idea of the person's the carbon dioxide level. If things were good, it should rhyme, it should correlate. It's not going to be, of course, the same values, but it should rhyme with the arterial carbon dioxide values, and therefore give an idea of ventilatory efficiency. Because we said earlier on, carbon dioxide is related to ventilation. So if carbon dioxide is high, it means ventilation is failing. It's inversely related to ventilation. So if carbon dioxide is high, ventilation is poor. So if we're seeing the capnography becoming high, that's the carbon dioxide exhaled at the level of the mouth or nose, if it's being high, it means that the person's ventilation is poor, isn't it? But here is the problem. There are two things to that. Capnography means that we are assuming that the person's ventilated air is coming up from the level of the alveolus, coming through the trachea, coming to the bronchi, coming to the trachea, coming to the upper airways before it gets to where the sensor capnograph, of the capnometer is. You see the thing. So, and it passes through all these areas called dead space. And that's it makes it tricky, because if for some reason, and it's the reason why, is because of the phenomenon of dead space wash through. It's because of that the correlation with the capnography measured carbon dioxide isn't exactly rhyming with that of the alveolus. I personally, I like the use of capnography. Personally, I do, but the most precise one, sorry friends, is the invasive one, which is the most precise method for measuring the carbon dioxide level is the invasive one, and that is arterial. We can in special circumstances we can manage the venous blood gas, but that is also invasive because it involves using a hollow needle to also access. This time it's a vein. We can also use capillary blood gas, but all of them are invasive because they involve pricking a vessel. Arterial pricks an artery, venous pricks a vein, capillary pricks the ear lobe and gets blood out through the capillary. So you see, while capnometry is there, it comes with its pluses and minuses. Then another one that is used also, is the transcutaneous CO2. That's the one that is indirect. It's also kind of it's non-invasive because you just clip it on the earlobe or any very well vascularized structure. You understand, and you measure it from there. It hasn't gained as much traction as the arterial blood gas simply because it also has this problem of correlating very perfectly. It doesn't have a perfect correlation with arterial blood gas. I mean, if it correlated perfectly with arterial blood gas, we will drop the ABG. You understand? It's very invasive. You do it, you see patients in pain. No. You understand? So while we have non-invasive things like end-tidal CO2 of capnometry and transcutaneous CO2, no. The ABG is still, I'm sorry, it's invasive, but it's still the place to be. All right. Sorry, I know. I wish I had more, happy answers, but it's not a sad answer. It's just that, and that's where we are. So for mobilization, yes, it's important to mobilize patients, but then we have to mobilize them when it is feasible to do so. Obviously, somebody who is on the endotracheal tube, the best mobilization we can do for such people are things like proning, you understand, left lateral, you understand, semi-upright with lateral positioning. These are some the physiotherapeutic things that we can do for the person at that time the person is intubated. We can also do it for non-intubated people, but then we can't mobilize somebody who's on. We can't walk. Obviously, we can never walk somebody who is on the tube. Of course, now it doesn't happen. The tube comes with a degree of sedation, you understand, and all that. So the other thing you asked about mobilization was about how early is it to mobilize. If the earliest one can be mobilized is a clinical judgment decision. First of all, the person should not be on any kind of intubation. The person can be on a break, because even when we're giving NIV, we allow them to have breaks for things like eating, drinking, going to the toilet, you understand. So, but the idea is that we have to make sure that those people are able to protect the person is able to protect his airway. So the person should have a good cough reflex, for instance. The person should have an intact cough reflex, you understand. So if the person can protect his airway, the person can mobilize, the person is able to move, you understand. So it can be attempted, and mobilizing people during physiotherapy is a graded, it's a stage thing. So we have, sitting up in bed, then we have from sitting to standing, you understand, before talking about walking. So it's something that is not rushed into moving the person. So usually when the physiotherapy will come, the first things to assess will be ability to sit up, ability to go from sitting to standing, ability to sit in the chair, ability to stand on your own. Do you need assistance of 1 or 2 or 3? You need a walker. So is a graded thing, you understand. So there usually isn't a problem if you grade the movement, if you do it in a graded manner. All right, people. Sorry for taking so long to answer your question. Sorry about that.
Actually, Doctor, thank you very much for your answers.
Now we have Paul.
Sorry.
Mr. Dennis, are you okay with his answers, or you need more clarification?
Yes,
No,
yes, yes.
no. If
I
you're not
just
okay,
want
let
to,
me know, please. Go ahead.
yeah, I just want to know much about capnography and capnometry.
Sorry, can we have one talk on?
Is this able to see them on the monitor or on the vent? Or there's a special machine to see it separately?
Yes. It's just the demonstration. You understand of the CO2 level, the tracing of the CO2 is a graph. It's a graphical demonstration of the CO2 tracing. That's all. That's what we're talking about when we talk about the capnography. And it's the ventilators usually should have it. It is something that can be attached. You understand? It's by no means, it doesn't come by any means with all the ventilator models, but it's something that can be fitted, you understand, to the endotracheal tube, and it measures it. It's like something that's coupled onto it. It also comes in. It can also be seen when people are undergoing a cardiopulmonary resuscitation. It's a good adjunct. So basically, it can be fitted onto an AET tube, and then it can give. You can see the display of the readings on the monitor. Yes. Yeah, that's how the capnography and the capnography measurement work. Yeah.
Thank you very much for the response. Thank you very much.
It's a pleasure.
Mr. Paul, you have this one now.
Okay, thank you. Good evening. The presenter, thank you for.
Hi.
My question.
Hi, Paul.
Yeah, hi. My question is still on the diagnosis aspect. Though you have said the gold standard is the invasive side, the arterial gas.
Sorry, guys.
But you made mention of X-ray and other scan. Please,
Yeah.
what are the features you are expected to see in the X-ray?
That's the thing.
I expected to see in the X-ray.
Yeah. Thank you very much. X-ray it serves to aid in narrowing down the diagnosis to one or two, to what it says. You understand? So the X-ray will depend on what diagnosis is causing it. Some diagnoses will have a normal appearing chest X-ray. Let me give you an example. An example of something like severe pulmonary hypertension, where the amount of the pressure in the pulmonary artery is so high that it's not picking up oxygen well. You understand? If you look at the patient X-ray, you see the heart there, you see the bronchi there, you see the trachea, everything is not looking at you. But then the idea that is the chest X-ray will not be sensitive enough to pick up what is going on at the level of pulmonary artery. But however, if you look at such a person's X-ray, you see, okay, a normal appearing chest X-ray. That way you can say, okay, this person does not have pneumonia, the person does not have heart failure, they don't have lung collapse. You understand? So the chest X-ray helps to narrow or exclude certain types of diagnoses. You understand? So yeah, in that kind of situation of somebody, this example I gave of severe pulmonary hypertension, it has excluded things like pneumonia, heart failure, lung collapse. You understand? Bronchial obstruction, foreign body aspiration. You understand? So it has excluded them, but it has not excluded something like pulmonary embolism. It has not excluded something like pulmonary hypertension. You understand? It has not excluded, so the chest X-ray will help in narrowing down some diagnoses, but it might not pick up some others. So it's useful, you understand? But it's when we're talking about what the diagnosis is it's useful in some diagnoses and not so much in others. You understand? That's etiology. You understand the etiology underlying the respiratory failure. So we diagnose the respiratory failure with ABG. So we're now saying, okay, what is the underlying pathology? What is the thing that's going on? Where is the issue coming from? Is it in the chest? Is it heart failure? Is it, you understand? Is it circulatory failure? So these are the things. Yeah.
So I'm expecting to, because that is my second comment, to see maybe an X-ray view where you can point out one or two things in your slide.
Okay, okay. Yeah. That would have added more, but yeah, I agree. Fine. Thanks for the observation. Good observation. Yeah.
Okay. I don't know if you have any question coming from the YouTube.
Okay.
Hello, Dayo.
Okay, we don't have any question from the YouTube, from those streaming on YouTube.
Okay. Do we still have any hands up?
Can I quickly make a comment?
Oh, yes, please. No, somebody wants to make a comment, please.
All right, thank you. Once again, I really appreciate. Yeah,
It's a pleasure.
the first question I was asked earlier about mobilization, that was where I like to make a comment as a physio. If I get a patient bedside, a patient is on NIV, I'll definitely look out for the reason why the patient is on NIV. So if a patient is having a high CO2, obviously, discontinuing IV at that point is going to do more harm. So mobilization will not be appropriate at that point in time in terms of getting out of bed. Just on the viewpoint of physio. But however, again, if a patient is on NIV, and one of the reasons why the patient is accumulating CO2 is probably because of a chest or secretions within the chest, so to say. So at that point in time, if I'm skilled enough, one of the things I can do is to adjust the parameters on the NIV machine to help with mobilization of secretion within the chest as against getting the patient out. Because of which we know, like you mentioned earlier on, if you're trying to get ventilation or air into the chest, it will bypass through the collateral ventilations and then mobilize secretion where it can probably be easily coughed out or suctioned out. So if I'm skillful enough, I can do a little of incremental pressure on the NIV just to give that person that back pressure into the airway to mobilize secretion. And then at that point in time, I think I've contributed possibly to the patient's management as against being anxious or being a little bit too ambitious about moving the patient out, which is going to do more harm. So I think that's the comment I wanted to mention about the NIV aspect of it that was asked earlier.
Okay. Thank you for the contribution. Yeah. So if somebody is unsafe for mobilization, is better to have the patient more stable. You understand? Before we talk about mobilizing the person, I think that's what you're trying to say. And with respect to the secretions, somebody who has a lot of secretions, and the truth is, if the secretions are quite much, and you can see the person obviously trying to cough up a lot of things, out of secretions, it is best to address the secretions before beginning to apply positive airway pressure, either in the form of CPAP or the form of bilevel PAP. Let me say it again. If somebody is overloaded with secretions, it is best to apply physiotherapy at that time. The person is overloaded with secretions. Take off some of the secretions, free up the airway a little bit before the person is exposed to positive airway pressure. Because at that time, if the person is having a lot of secretions, actually NIV, BiPAP, bilevel PAP, CPAP, they're actually relatively contraindicated at the time when there's a heavy load of secretions. You understand? It's actually in guidelines. It's actually stated as such. When there's a heavy load of secretions, do not. You should preferentially not commence NIV or anything that is PAP, but try to address the secretions before you now begin the NIV. Okay, yeah, but it's basically what you have said, and thanks a lot for pointing that out. Yeah.
Thank you so much, Mr. Ayubu.
Thank you.
All right, you're welcome.
I think I see a hand up.
Lovely.
Please, can you ask your question? Thank you.
Yes, I'm waiting for the question, please.
I think Mr. Ayubu, I think you still have your hand raised up. Oh, okay.
Are there any questions in the messages, like the chat messages?
I can't see anyone on the chat.
Okay.
We've really gone far.
It's an honor to talk with a noble crowd like you guys. I'm very happy and honored. Thank you for considering me for this discussion. I'm very happy that we've rubbed minds, and we grow together. You understand? We are growing together. That is it's beautiful.
I don't think we have any question. Please, can we still share our emojis and appreciate Dr. Ikekeonwu for this wonderful exposure and a presentation. I mean, we all laughed together and we all celebrated together. So we want to use this opportunity, the cardio education group, heavily check